Now that you have a good understanding of the anatomy of the GI tract and the functioning of digestion, I want to take a look now at diseases of the GI tract. The first gastrointestinal problem I want to talk about is constipation. It's prevalent in 10 to 15% of the population as self-reported, and in approximately 30 to 40% of those over 65 years of age. And that's primarily because of lack of exercise and also because of the medications that they're taking oftentimes have a constipation as a secondary effect. The diagnostic criteria for constipation is having less than 3 defecations per week and straining in more than 25% of the defecations, and also having a sense of incomplete evacuation in more than 25% of the defecation experiences. Here are the recognizable symptoms of constipation: bloating, abdominal pain, and discomfort. The causes are threefold: poor dietary fiber intake, less than 25 grams per day on average, an inactive lifestyle, so not a lot of walking and movement, so probably sitting quite a bit, the use of analgesics, antidepressants, and antihypertensive drugs. As I was mentioning, some of these are used after the age of 65, so these have a tendency to increase constipation. The treatment of constipation, short-term constipation could be treated with laxatives, but not long-term. Chronic constipation need long-term lifestyle changes: more fiber, 25 to 38 grams per day, regular physical activity, and adequate hydration. The second condition that I want to look at is gastroesophageal reflux, or GER. GER is commonly known as heartburn. Acid from the stomach refluxes back into the esophagus, causing a burning sensation. It represents about 1.2 billion in sales of antacids. The treatment is antacid to neutralize the acid, avoid overeating, and oftentimes limit stimulants like coffee, alcohol, and spicy foods. The next condition is very similar. It's called gastroesophageal reflux disease, or GERD. GERD is more of a chronic form of acid reflux. The lower esophageal sphincter, LES, becomes laxed, allowing HCl, hydrochloric acid, to flow up the esophagus. It sometimes will lead to Schatzki's ring, which is formed right around the area of the lower esophageal sphincter. The symptoms are heartburn, dry cough, sore throat, nausea, pain in the chest and upper abdomen, bad breath, and difficulty swallowing. If Schatzki's ring is formed, it creates significantly more difficulty swallowing, pain in the in the upper chest area, and this can be solved through a surgical removal of the Schatzki ring. The condition of GERD is linked to obesity, to pregnancy, to the use of antihistamines, sedatives and antidepressants, and also to smoking. The secondary effects are chronic esophagitis, erosive esophagitis, possible bleeding and ulceration, precancerous changes to the esophageal lining. The treatment for GERD is losing weight, avoiding smoking, small frequent meals, upright position 3 hours after a meal, and antacids are also an option. The next condition I want to look at is peptic ulcer disease. It's a condition that refers to ulcer formation in the esophagus, the duodenum, and the stomach, and it affects about 500,000 people per year. Now, the symptoms are nausea and bloating, vomiting, and weight loss, and the causes originally thought to be due to excessive spicy foods or stress or excessive alcohol consumption. More recently, in the last 20 years, Helicobacter pylori was identified as the main cause of peptic ulcer disease in a significant number of cases, but not in all. The traditional treatment was bland diets, limited spice, and no alcohol. Contemporary approaches, the mid 70s to 90s, it became diet is tolerated. So they found that patients' tolerance varied from patient to patient. So it was really up to the patient to decide what they were able to tolerate. There didn't seem to be a uniform diet that applied to everyone. Since the 1990s, with the discovery of Helicobacter pylori, a priority is given to using antibiotics to actually resolve the ulcer. But it's not everyone that has an ulcer that has necessarily Helicobacter pylori. There's also the use of proton pump inhibitors or H2 blockers that help control the acid production. There's also the use of bismuth subsalicylates or Pepto-Bismol to actually coat the lining of the stomach and help reduce the pain there. And of course, breath and stool tests are now used to check on the efficacy of the antibiotics. The idea here is because a lot of these patients do in fact have bad breath. If the antibiotic is correctly, efficacious, the bad breath should actually decline with the use of the antibiotic. The next disease is diverticular disease. The first is diverticulosis. It's the formation really of outpouches formed along the descending colon. There's an intraluminal pressure resulting from hard stool that pushes against the colonic wall. Over a 10 to 20 year period, this pressure causes outpouches, or what we call diverticuli, to actually be formed. The infected diverticuli uh, results in diverticulitis. So the diverticulosis becomes diverticulitis once the diverticulae, that is to say the pouches, become infected with fecal material. It begins usually to appear after the age of 40, but there is evidence now emerging because of the poorer diets of the youth that diverticulosis and diverticulitis will likely be appearing at younger ages. The assessment is a colonoscopy, and they also use barium enemas and x-rays to actually verify if the colonic wall has these outpouches. The treatment, especially in serious cases where there's a lot of diverticulitis, a lot of inflammation, a lot of bleeding taking place, surgical resection will take place in advanced cases. This basically means parts of the colon gets removed. Otherwise, you're looking at a diet that's high in fiber. The next conditions are hemorrhoids, anal fistulas, and anal fissures. Hemorrhoids occur in about 75% of US population, um, and it's prevalent in the 45 to 65-year-old range. Really, a hemorrhoid is an inflamed vein surrounding the lower rectum. Uh, Chronic relapsed hemorrhoids may actually need surgery. So these are essentially hemorrhoids that protrude out. The causes of the hemorrhoids are really two causes: chronic constipation or pushing really hard during pregnancy deliveries. So it's truly a dietary condition and also lifestyle. Anal fissures are slight linear cracks or tears of the anal mucosa. Now, it usually requires then a fiber intake about 25 to 38 grams per day, and this is in order to soften the stool so that when people experience defecation, they're not forcing as much and therefore causing tears. The soluble, insoluble fibers will soften the stool and shorten the transit time and therefore diminish this desire to want to force the stool out. Anal fistulas are transfincteric roots that pierce through the buttocks. So they actually travel through from the anus right all the way to the buttocks, and they're treated with fistulotomies and antibiotics. So this is basically a canal that gets created by the bacteria resulting from the fissure um, in the anal area. Anal fistulas really result from chronic bad management um, of going to the toilet and holding perhaps the fecal material longer than it should, having a bad diet low in fiber, not moving a lot, not having a lot of exercise, typically seen in truck drivers that are traveling long distances, that don't really exercise very well, and that have terrible diets low in fiber, high in fat. The anal fistulas oftentimes will require that the transsphincteric route, which is full of pus, be drained and cleaned out in order to favorably allow the healing process. Next, I want to give you the highlights of inflammatory bowel disease. The first is Crohn's disease. It consists of deep fissures that go through all the layers of the intestinal wall. And it can affect both the small and the large intestine, but it's mostly the ileum and the colon in about 45% of the cases. Uh, Diagnosing Crohn's disease will take place with colonoscopies, sigmoidoscopies, CT scans, and maybe upper GI series using barium. But you can see in the graph right here that what you're looking at are deep fissures that go through to the muscle. So they go from the mucosa right down to the muscle. So they're deep fissures that affect really in a serious way the absorption of nutrients for these individuals. So the mucosa becomes inflamed and also creates these fissures. The symptoms of the disease are abdominal pain and diarrhea, and oftentimes there's malabsorption in which vitamin D and B12 and iron are actually compromised. There's a growth retardation in children and oftentimes a diagnosable iron deficiency anemia. Now, patients will experience fear of eating as a result of this disease and the pain that's associated with it. There's a Vienna classification, and there's also a Montreal modification in the classification of Crohn's disease. Patients that have Crohn's disease need to be regularly monitored for anemia, low protein status, hypoalbuminemia, electrolyte imbalances, and vitamin D status using serum hydroxy 25 vitamin D, and this every 2 years. And then serum B12 needs to be monitored as well every 2 years. And bone density needs to be measured using DEXA. Now, the treatment plan for Crohn's disease consists of steroids like prednisone or budesonide during the flare-up period. Long-term management involves the use of anti-inflammatory medications like sulfasalazine, and about 67% of patients suffer from intestinal blockage, perforations, bleeding, or abscesses. If damage is extensive enough, a resection or a removal of the perforated area is performed. For treatment, though, total parenteral nutrition is prescribed during periods of inflammation to allow lesions to heal. So in other words, total parenteral nutrition is intravenous feeding. So it is generally recommended that the gut be rested and that they don't eat by mouth because of the chances that it may irritate or further aggravate the ulceration or the inflammation in the intestine. There's little absorption, remember, and there's a lot of diarrhea. So the rationale then is to feed through the veins, and total parenteral nutrition, TPN, is all the nutrition coming in through the veins, and that's generally recommended in these cases. The other thing to remember is because of the risk of blockages of the intestine, again, a good reason to avoid feeding through the gut. Now, inflammatory bowel disease also includes ulcerative colitis, and you can see looking at the images that there's a bit of a difference here to note. For instance, in Crohn's disease, you're looking at ulcerations that go through the mucosa, the submucosa, into the muscularis or into the muscle area. But for ulcerative colitis, you're looking at ulceration strictly limited to the mucosa. So patients with ulcerative colitis are more prevalent than patients with Crohn's disease. And contrary to Crohn's disease, which includes both the small intestine and the colon, ulcerative colitis is pretty much limited to the colon or the large intestine. As I mentioned, only the small or the mucosal layer is affected, and it doesn't go as deep as Crohn's disease. So patients with no abscesses or fistulas, is generally how it gets presented. Um, Abdominal cramps, frequent bowel movements, bloody diarrhea with mucus is oftentimes encountered in these patients. But because it's only the mucosa that's affected, there are fewer nutrient deficiencies. In other words, there's a bit more absorption going on here in ulcerative colitis than you would see in Crohn's disease. There is nevertheless poor growth in children, not enough calories coming in, mostly because of the fear of eating, not so much because of the poor absorption. Now, it's important to make this distinction. Irritable bowel syndrome is not an inflammatory bowel disease, and the main reason is evident in the symptoms. The GI tract is not inflamed as in Crohn's disease or ulcerative colitis. Abdominal pain and discomfort, diarrhea, and constipation certainly are present and they affect the quality of life. So the symptoms make this disease very real. Now, the causes of IBS, the reasons for the unpredictable motility are not clear. Strong mental health components are tied to the anxiety, to depression, um, and related to panic disorder, to post-traumatic disorder. So certainly all of these factors somehow conspire together to create this irregularity in motility. Now, the treatment is liberal, but healthy diet is tolerated. So, in other words, some foods affect some people, but other people will be affected by another set of foods. So, we leave it liberal in that way, but we try to guide people towards a healthy diet. Fiber intake is encouraged, it appears, to keep the fiber intake to less than 40 grams, but bringing it up nevertheless significantly brings a certain stability to that irregular motility. Consuming probiotic foods appear to have some benefits. Consuming small but frequent meals. In other words, avoiding over-consuming at one meal. Keep the portion sizes small. Antispasmodic drugs like hyoscine, aromatic oils like peppermint, and regular exercise. I've seen significant improvements in patients with IBS through the implementation of regular exercise programs that are consistent and that are moderate to strenuous. Now I want to look at short bowel syndrome. And in order to have a problem with short bowel syndrome, you have to have gone through a basic resection or a removal of parts of your bowel. So a resection of more than 100 centimeters, for example, of the ileum, if less than 100 centimeters of the jejunum is left and no ileum is left, that tends to lead to a short bowel syndrome. What are the symptoms? Well, diarrhea, malabsorption, There's malabsorption of bile, because remember, the bile gets reabsorbed in the ileum at the level of the ileum through the enterohepatic circulation. So this is where the bile gets reabsorbed, recirculated back to the liver, and also we have a malabsorption of B12 oftentimes in these short bowel syndromes as well, especially when significant amounts of the ileum has been removed, because it's in the ileum that the B12 is actually absorbed using the intrinsic factor. So the treatments for short bowel syndrome, well, total resection of the jejunum, for example, usually leads to total parenteral nutrition for life. That basically means complete nutrition in the form of a liquid that's passed into the veins. The diet of 40% fat with no steatorrhea. Here we define steatorrhea as fat in the stool. 45% carbs and 15% protein is another, sort of combination here, right? But again, when we have 40% fat, there's got to be evidence of no residual fat in the stool. If there is fat in the stool, then the fat level has to go down in the diet, and of course the carbs and the protein get changed. There is a restriction of simple sugars, because the simple sugars cause, if you will, or precipitate this short bowel syndrome, which really is, again, that diarrhea that takes place. So by restricting the sugars, there's less of that diarrhea. Drug therapy, loperamide, which is an antidiarrheal, cholestyramine, which binds the bile salts. And if you remember, the problem here is that the bile salts cannot get returned through the enterohepatic circulation, and this is because parts of the ileum is oftentimes removed, right, at greater than 100 centimeters of the ileum. So consequently, if they give cholestyramine, you'll remember from a previous slide that it actually binds the salts and consequently diminishes, as a result of that, the amount of bile that goes back to the liver, if you remember, and reduces cholesterol. But here, cholestyramine, because it binds the salts will actually go through the colon and the fecal material, and it will diminish as a result, or manage, if you will, this residual bile. H2 pump inhibitors, this diminishes the hydrochloric acid secretion from the stomach, and that also is a factor that precipitates, if you will, the short bowel syndrome. Now I want to explore instances when low-fat diets are actually needed. So first, let's define a low to moderate fat level. A low-fat diet is generally regarded as less than 25 grams per day. It's about 11.25%, if you will, of a 2,000 calorie day diet. A moderately low-fat diet is less than 50 grams per day, but certainly more than 25. Moderately low levels of fat would be about 22.5% of a 2,000 calorie diet. So what we know from this is, if we consider the healthy macronutrient ranges for fat, which is 20 to 35, that a low-fat diet, because it's at 11%, could only be considered on a temporary basis. So you wouldn't put a patient long-term on a low-fat diet, but you could on a moderately low-fat diet. Now, in instances of fat malabsorption, most foods need to contain less than a gram of fat per serving. The dietary product allowances would be like fat-free milk. Most breads would be acceptable. Lean meats, about 4 to 6 ounces per day, and about 1 to 3 grams of fat per 2 to 3 ounce servings. Cooked grains like rice and pasta would be acceptable, and fat-free broth and soups would be fine. And of course, all vegetables prepared, of course, with no fat, and all fruits would be permitted. Now, by contrast, foods that would be restricted would be whole milk because of the fat content, baked products because a lot of fat basically in baked products, a lot of shortening, a lot of butter, and so forth. Um, Meats would be restricted to 4 to 6 ounces per day, and you'd have to restrict meats that had 5 to 10 grams of fat per 2 to 3 ounce servings. So that would be considered perhaps more fat than the person should actually require on a low-fat diet. Sometimes lactose-based products are actually eliminated from low-fat diets because they exacerbate the condition of malabsorption in the gastrointestinal tract. So now I want to propose looking at a case study of bowel disease, and it involves a 45-year-old man with abdominal pain who presents to urgent care. This patient presents as a 45-year-old male who is mildly ill, but in no distress, to urgent care with worsening lower left quadrant sharp pain for at least 3 days. He has low-grade fever, he complains of fatigue, vomiting, and general malaise, history of chronic constipation. No history here of inflammatory bowel disease or irritable bowel syndrome. No diarrhea, rectal bleeding, melena, chest pain, shortness of breath, or anorexia. Melena is the equivalent of coffee ground-like blood found in the stool, and it's generally a symbol or an indicator of an upper GI bleed. The examination reveals tenderness with palpitation of the lower left quadrant, no guarding or rebound tenderness. Let's take a look at the blood biochemistry and some of the other diagnostic tools that were used to evaluate this patient. First, the complete blood count, CBC, appears normal except for an elevated white blood cell count. Comprehensive metabolic panel just seems pretty normal. The erythrocyte sedimentation rate, which is kind of an indicator of inflammation in the body. Red blood cells, when they're put into a tube, normally gravitate or move to the bottom and sediment at the bottom of the tube at a relatively slow rate. But when there's inflammation in the system, the red blood cells clump together and appear then to drop to the bottom of the tube much faster. And we call that a sedimentation rate that's faster, that's indicative of inflammation. In this case, there's no indication here, so it appears normal. The C-reactive protein is also a protein that is reflective of not sedimentation, but rather of inflammation, and that also appears normal. And the urine analysis appears normal. We did some imaging assessments, and there appears to be a left-sided colonic diverticulitis, so an inflammation of the left side of the colon, which is really in the descending, the descending colon component where the diverticulosis generally takes place. In this case, diverticulitis means that there's an inflammation. So the treatment is going to be a stool softener. There's going to be an antibiotic prescription, and there's going to be a referral to a dietitian to consider a diet, to teach a diet to the patient that involves higher fiber. So at this point, I'd like you to pause the video and describe the kind of diet the dietitian will teach the patient and describe the rationale for such a diet. If you answered correctly, you should have an entry that resembles this. To prevent the reoccurrence of diverticulitis, the inflammation of the diverticulae in the descending colon, the dietitian will prescribe for the long term a diet consistent with healthy eating guidelines for Americans, ensuring a minimum of 5 servings equivalents of fruit and vegetables per day, only whole grain products as in whole wheat bread, brown rice, whole wheat pasta, and a high fiber breakfast cereal every morning. Looking at the table in your chapter, you can select among the high fiber cereals there. A half a cup of fiber 1 will provide about 14 grams per serving. Carbohydrates should be elevated in the diet. These would be complex carbohydrates, 60% of the DRI calories, protein about 15%, and fat 25% of the DRI calories. Let's take a look at another case study involving inflammatory bowel disease. In this case, we have a 23-year-old female with IBD. This case can also be found in your textbook. This is a 23-year-old female college senior who presents to family practice with a 2-week history of a worsening abdominal pain. Complains of loose stools for about 3 to 4 days. Now has 8 to 9 liquid stools per day. Complains of aching and burning pain in the upper and lower abdomen, mild to severe pain. Patient complains of not being able to work and has also reported unwanted weight loss. She looks pale and miserable, complains of pain worsening after each meal. Now, what are the symptoms? Well, almost complete loss of appetite. She has fever, debilitating fatigue and general malaise. She has pallor, bleeding stools, no melena, body aches, or chills. The past history reveals no past medical history. Patient has been in perfect health and has not taken any kind of medication. What else have we uncovered about this patient? Well, patient is ill in appearance, but there's no distress. Appears thin, but no cachexia. And cachexia is really an advanced emaciation or advanced wasting of muscle tissue. The skin is pale. Tachycardia is reported. Lungs are clear. Abdomen is soft, non-distended. Pain with palpitation over the right, upper, and lower abdomen. Hemo-occult measurements are positive, indicating, of course, blood in the stool. Let's look at the biochemistry. Low hemoglobin, low potassium. C-reactive protein is elevated, and the erythrocyte sedimentation rate, the ESR, is also high. Both the C-reactive protein and erythrocyte sedimentation rates indicate inflammation in the body. Diagnostic imaging, CT scan of the abdomen reveals a transmural colonic inflammation at the ileocecal valve. Colonoscopy reveals inflammation and constriction of the ileocecal valve. Biopsy results consistent with Crohn's disease. So prescription, in terms of an immediate prescription, nothing by mouth, which is NPO, in order to ensure bowel rest. Stabilize with steroids, notably prednisone. Immune modulator therapy will be given to affect the remission. So overall, what we're trying to do is ensure bowel rest by not providing any food by mouth. We'll likely implement total parenteral nutrition on the short term, right until the patient is stable and there's no more evidence of inflammation of the bowel. Let's take a closer look at the dietary treatment. So a feeding line will be peripherally implemented in order to provide the nutrition. When it's given peripherally like this, it's called peripheral parenteral nutrition, or PPN. The caloric requirement will be determined using a new equation called the Harris-Benedict equation, and it's going to be viewed in the next chapter. But you can move ahead to chapter 7 and see what this Harris-Benedict equation, usually dedicated to in-hospital patients, looks like. There's also in the table in the next chapter injury factors that are provided to the patient. So in this case, we're going to be using an injury factor of 1.25. And that usually is tied to a moderate infection. And patient will be fed until the inflammation is subsided. And up until then, the PPN will be given. Then it will transition to a clear fluid, followed by a full fluid, and then a mechanical soft, and then ultimately on to a regular meal plan as tolerated. So now I want to define a few concepts. Here, if the liquid nutrition is administered into the largest vein in the body, the superior vena cava, and it provides the majority of the nutritional needs, it's called total parenteral nutrition, or TPN. In this case, the nutrition solution is given into veins outside of the superior vena cava, so it's not a central vein. This is called peripheral parenteral nutrition, or PPN. PPN does not provide the total nutritional requirements of the patient, but it gives quite a bit of that nutritional requirement. It's easier to implement, and it's not using a central vein, for example, that subjects the patient to a higher risk of infection. So it's easy to implement, and it's a logical choice here because the goal is really a short-term management of the patient's requirements right up until the inflammation subsides. Now I want to take a bit of time to look more closely at the transitional diet that was referred to earlier. The transitional diet is a diet that's implemented to allow a slower movement or transition from like a TPN or a PPN to reintroduce not heavy food, calorically dense food immediately, because the gut is actually not well prepared, right? It's been resting in this particular case. So we begin with a clear fluid, then a full fluid, a mechanical soft diet, and then ultimately a regular diet as tolerated. This particular slow transition into a regular diet as tolerated allows a better tolerance of the food during that period of transition. How about some details regarding the clear liquid diet? Well, patients that receive the clear liquid diet underwent some kind of bowel surgery, maybe colonoscopy, transition after intravenous feeding over the short term. And it consists of beef or chicken bouillon, a juice or different juices with no pulp, and the food should be normally liquid at no temperature with no residue. As the patient is able to tolerate the clear liquids, then there is a transition to full liquids or full fluids. The transition involves the introduction of milk, milkshakes, eggnogs, cream soups, and thin cereal gruels. So this allows the patient to get a little bit more nutrition. Traditionally, we don't really like to see patients staying on clear fluids very long, but certainly we can sustain them a little longer on full fluids or full liquids, as the nutrition is a little denser. Well, the general idea behind a mechanical soft is that it doesn't require much chewing. So we have examples of milk products, which are very popular: milk, yogurt that has some soft fruit in it, pudding, cottage cheese. And then fruits, such as soft fruits, canned, cooked fruits, no seeds. Fruit juice, small amounts of pulp permitted. And a ripe banana, for example, is very popular. As far as vegetables go, they just simply need to be well cooked. Moist potatoes, for example, so not that hard, but moist, that break apart very easily. So you can see that a mechanically soft diet actually meets a lot of the nutritional needs of the patient. It has variety and has consistency, but it involves really minimal chewing and presumably easier digestion and absorption. Well, how about a training quiz on gastrointestinal diseases and diet? First question: identify below the gastrointestinal disease for which there is no pathophysiology, but yet the symptoms of abdominal pain are real. Pause the video here and select your answer. The correct answer is D, irritable bowel syndrome, IBS. There is indeed no sign of inflammation inside of the GI tract, but yet the irregular motility inside the GI tract does create a lot of discomfort for the patients. Second question, identify the gastrointestinal condition that has deep fissures of the intestinal wall that affect the mucosa and the muscularis layers. Pause the video here and select your answer. When there are deep fissures that affect both the mucosa, the submucosa, and the muscularis, we're looking at B, Crohn's disease. Remember that Crohn's disease can affect both the small intestine and it can also affect the colon. Question 3. Identify below the known causes of most peptic ulcers. Pause here and select your answer. The correct answer is D, Helicobacter pylori infestation, treated with antibiotics. Next question, identify below the nutrients that are most closely monitored in Crohn's disease. Pause the video here and select your answer. The correct answer is E, vitamins D, B12, iron, and some additional minerals. Next question, identify below the gastrointestinal disease likely to be diagnosed with inflammation of mucosa, some blood in the stool, no melena, and iron deficiency anemia. Pause here and select your answer. The correct answer is B, ulcerative colitis. Next question, identify below the gastrointestinal disease likely to be diagnosed with abdominal pain in the left lower quadrant, some blood in the stool, no melena. Colonoscopy reveals inflamed diverticula. Pause here and select your answer. The correct answer is diverticulitis. Now, if you selected diverticulosis, you are likely going to be referring to the actual pockets or diverticula that are along the descending colon. However, diverticulitis is the inflammation of the diverticula, and in this case, it's diverticulitis. Last question. Patient presents with abdominal pain. The CT scan reveals transmural colonic inflammation at the ileocecal valve. Patient has frequent diarrhea with blood in the stool and with melena. What diet should be prescribed? Stop here and select your answer. Well, the transmural colonic inflammation at the ileocecal valve sort of suggests something like Crohn's disease. There's diarrhea, there's blood in the stool, and consequently we need to be thinking about resting this bowel. So NPO, nothing by mouth, for bowel rest is certainly the short-term diet protocol that should be followed. The melena implies a tar-like stool, black in color, likely arising from something going on in the upper GI tract closer to the stomach because of the acid that's coming from the stomach, likely coagulating the blood that basically is arising from that area. This is certainly consistent with Crohn's disease, as we know that the small intestine as well as the colon can be affected by this particular type of inflammation. This is the end of the presentation, and I encourage students to read Chapter 6 in the book. There is in addition a section on celiac disease which is not covered in this video lecture, so I encourage you to do that and to practice these questions some more.